Good morning, everyone. I'm glad you could all join us today. We're here for the child psychiatry grand rounds. And we're going to see a presentation today by Stephanie Violante, and who is one of our clinical psychology interns at the UCLA Semel Institute for Neuroscience and Human Behavior. She completed her undergraduate studies in psychology at the University of Washington in Seattle and is currently in the last year of her doctoral program in clinical psychology at Virginia Commonwealth University. Her research to date has been focused in the areas of implementation science, treatment integrity, and measure development. Throughout her graduate career, her research was primarily conducted in pediatric anxiety populations. So she has enjoyed learning more about family therapy as she has applied her interest to new populations for her dissertation. She has also clinical experience in outpatient, integrated primary care, and pediatric medical settings, working with children and adolescents with a range of mental and behavioral health problems. I'm particularly looking forward to her presentation today. If I didn't introduce myself, I'm Dr. Berenstein, Dr. Veronica Berenstein, and many of you know, I teach family therapy to many of our trainees. So I'm looking forward to this presentation, really looking at family therapy and how to try to see the outcome and find the real outcome and figure out how you do that. So that's always been an issue with outcome research. So without further ado, here's Stephanie Violante.
All right, so I will share my screen. All right, hi everybody. Thank you so much for coming today. And thank you to Dr. Berenstein for agreeing to introduce me and moderate the Q&A. I want to start by saying that I don't have any financial disclosures. And if you have any questions throughout the presentation, you can put them in the Q&A section. There's a little button on the line either on the top or bottom of your screen that says Q&A, and I will answer those at the end of the presentation. So as Dr. Berenstein said, I'm Stephanie Violante, and I'm a psychology intern here at UCLA. Today, I'm going to be talking about the assessment of treatment integrity and family therapy for adolescent externalizing problems. I'm going to be talking about conceptual considerations, as well as presenting some of the data from my dissertation. So today we'll be primarily talking about treatment integrity assessment, but I do want to start by orienting everybody to the specific populations that I'm going to be referring to, which includes adolescents with externalizing problems. For the purposes of this presentation, externalizing problems includes general behavioral problems, delinquent behaviors, and substance misuse. Adolescent externalizing problems are considered by many researchers and practitioners to be a public health problem. For example, conduct disorder in adolescents has a prevalence rate of between 5 and 9%, and substance use disorder, which only includes adolescents who meet full criteria for a disorder, not even adolescents who are otherwise misusing substances, has a prevalence rate of about 5%. And there's also a high comorbidity between these two, with research estimating somewhere between 17 and 85% of adolescents with a conduct disorder also meeting criteria for a substance use disorder. Adolescents with these problems are more likely to experience adverse outcomes, including family dysfunction, low academic achievement, problems with the law, and negative health outcomes, including death. When left untreated, these conduct and substance use problems in adolescents are likely to persist into adulthood and can impact social and occupational success. There are significant racial and ethnic disparities in the diagnosis and treatment of youth with behavioral problems that are very important to acknowledge. For example, conduct disorder has historically been overdiagnosed in youth of color compared to their white counterparts who have comparable behaviors. And Black youth are 2.5 times more likely to be diagnosed with conduct disorder than their white peers with similar presentations, who are instead more likely to be diagnosed with something like ADHD, PTSD, mood disorders, or developmental disorders. And we know that a diagnosis of conduct disorder can follow you and comes with a certain amount of stigma. One reason for these discrepancies is clinician bias, which can lead to clinicians asking different types of questions during diagnostic interviews or making differential interpretations about the etiology of an adolescent's behaviors or symptoms, which can lead to inappropriate diagnoses and then subsequently inappropriate treatment. There are also significant disparities in treatment, with youth of color being significantly less likely than white youth to receive appropriate mental health treatment following a diagnosis of conduct disorder. Youth of color are more likely than their white peers with similar behaviors to end up in juvenile justice systems rather than receive mental health support. So for youth who have accurately been identified as having primary externalizing problems versus those who have behavioral problems due to other things such as trauma, mood concerns, for example, the intervention approach with the highest level of empirical support is family therapy. Family therapy intervenes directly with family members to address dysfunctional interactions and challenges within the family system that contribute to the onset and maintenance of the adolescent's behavioral problems. Some of the most well-established family therapy interventions for adolescent externalizing problems include brief strategic family therapy, functional family therapy, multidimensional family therapy, and multi-systemic therapy. These interventions have been shown to not only reduce disruptive behavior and substance use among adolescents, but also to increase treatment engagement and retention and improve academic and peer functioning. Within the last 15 years or so, researchers led by UCLA's very own Dr. Bruce Torpeda and colleagues have proposed a shift toward prioritizing the delivery of core therapy practice elements rather than a specific manualized treatment. So core practice elements are discrete therapeutic techniques that are common across multiple evidence-based treatments for a given problem or disorder. For example, relaxation is a practice element that is found in almost every CBT manual for childhood anxiety. The delivery of core practice elements allows for more flexible treatment delivery than using one specific treatment manual, which allows clinicians to tailor their treatment to individual patient needs. Research has also shown that core practice elements are easier for community clinicians who have incredibly high caseloads and demands to learn and retain. Dr. Aaron Hogue and his team have distilled treatment manuals of family therapy for adolescent externalizing problems into 4 core elements. They named these elements interactional change, relational reframe, adolescent engagement, and relational emphasis. So the interactional change element represents therapists allowing or prompting family members to interact with each other in a session in order to naturally assess their family dynamics and any dysfunctional interactional patterns that may be contributing to the cause or maintenance of the adolescent's behavioral problems. This also includes therapists directing in-session interactions in order to promote more effective ways of relating. Relational reframe refers to therapist attempts to help the family reframe their understanding of the problem from being adolescent or symptom-centered to being a family or relational problem. This element is intended to increase family motivation to pursue changes in the family relationship as the primary clinical solution, rather than saying, here, work with my adolescent, it's their problem. Adolescent engagement refers to therapist efforts to understand the adolescent's individual point of view and to present family therapy as an opportunity to address problems that are personally meaningful to the adolescent, both within and outside the family. And relational emphasis represents therapeutic interventions that focus on family processes and where the therapist may intervene to improve overall family functioning. So for example, this may include discussions of triangulation or appropriate family roles, like if a child is being parentified. This is not to say that these are the only elements of family therapy, but for the purposes of assessing treatment integrity for family therapy, specifically for adolescents with externalizing problems, these are the elements that have been most commonly included in previous research on this topic. Evidence-based family therapy interventions, including both individual manualized treatments such as brief strategic family therapy, as well as more modular common elements-based family therapy, have been shown to be efficacious under controlled research conditions for adolescents with externalizing problems. And in these conditions, therapists generally receive high-quality training, ongoing supervision, and other types of ongoing support from research staff. But the effectiveness of these interventions when delivered in routine practice settings in the community has been less consistent. For example, in a meta-analysis of 52 randomized controlled trials, which compared evidence-based practices with usual clinical care in community mental health settings, with 1/3 of these trials being examining family therapy for adolescent externalizing problems, authors found that there was only a 58% chance, so a little more than a coin toss, that youth receiving an evidence-based practice would have better clinical outcomes than youth receiving usual clinical care. And this finding was consistent across types of evidence-based practices, including family therapy. So why are these treatments that are so efficacious in controlled settings not outperforming usual care in the community? It could be related to differences in patient populations. For example, youth treated in community settings are more likely to be racial or ethnic minorities compared to youth treated in research settings. And we know that evidence-based mental health treatments historically have not been designed for nor tested with non-white or non-Western populations. Additionally, youth treated in community mental health settings are more likely to have comorbid mental and behavioral health diagnoses, which is often an exclusion criterion for research studies. And youth in community settings are more likely to come from low income and single parent families, which can be associated with increased psychosocial stressors that may either interfere with or not be adequately addressed by evidence-based treatments. Another explanation for why evidence-based treatments often don't consistently outperform usual clinical care in community mental health settings focuses on differences in the delivery of the treatments themselves, which is the explanation that this presentation explores. Research suggests that therapists delivering evidence-based treatments in community practice settings tend to deliver lower doses of those treatment components than therapists in controlled research settings. And this can be due to a variety of factors, including education, training, supervision, patient needs, and lack of resources in those settings. It's also possible that the reason evidence-based treatments aren't outperforming usual care is because usual care therapists are actually delivering evidence-based treatments. So a usual care control group may not actually be as distinct from the evidence-based treatment group as we assume. In fact, research characterizing usual care treatment in community mental health settings indicates that usual care therapists do frequently deliver treatment components that are based in evidence. So how can we as researchers understand these mixed effectiveness findings? Our ability to accurately interpret results from an effectiveness trial requires a better understanding of what therapeutic techniques were delivered and to what extent across both treatment and usual care groups. So let's use an example of an effectiveness trial comparing family therapy to usual clinical care in a community mental health clinic. In this example, there were no significant differences found in clinical outcomes between the two groups. To be able to accurately interpret these findings and what's going on here, there are a few things that we need to know. First, were family therapy techniques actually delivered in the family therapy group? If not, we're not really looking at the effectiveness of family therapy. Second, were family therapy techniques delivered in usual care group? If so, we may be comparing family therapy to family therapy. And lastly, what other techniques were delivered in both groups that may affect clinical outcomes? Clinicians in community settings have eclectic styles and frequently modify interventions to meet the individual needs of their patients. So it's important for us to know what other techniques they're using that might be impacting clinical outcomes, both positively and negatively. And one way we can answer these three questions is through the assessment of treatment integrity. Treatment integrity is broadly defined as the degree to which an intervention is delivered as it was intended. Two of the components of treatment integrity include adherence and differentiation. Adherence can be defined as the extent to which prescribed therapeutic techniques are delivered, and differentiation can be thought of as the delivery of non-prescribed techniques. A helpful analogy for understanding the difference between adherence and differentiation is baking. So let's say we're baking chocolate chip cookies. Adherence would mean that we're using every core ingredient that goes into making chocolate chip cookies. Differentiation, on the other hand, would be including additional ingredients. So differentiation can include techniques that are not prescribed as part of a specific treatment being delivered, but are complementary to the treatment or can be helpful for a specific problem area. For example, some people like walnuts or oats in their chocolate chip cookies. But differentiation can also include techniques that may be ineffective or even harmful for a specific problem. So in our analogy, that would be like adding something like yellow mustard to the chocolate chip cookies. And if that's something that any of you like, no judgment, not for me personally. So we know that having an idea of treatment integrity can help us interpret trial results, but how do we measure it? For adherence, the majority of existing instruments are instruments that assess protocol adherence. And protocol adherence refers to adherence to a specific treatment manual or protocol, like brief strategic family therapy. And research assessing protocol adherence to family therapy has found that higher protocol adherence is associated with improved clinical outcomes. And that's great. But as I mentioned earlier, there has been a shift away from the delivery of specific manualized treatments and more toward the delivery of core evidence-based practice elements, especially in community mental health settings. And so we need an adherence instrument that can capture data at the core practice elements level. This type of adherence instrument can be used more flexibly and can be applied to multiple different manualized treatments. And there are a couple of adherence instruments like this for family therapy, which I will get into in a couple of slides. And research using these instruments has found that similar to protocol adherence, adherence to core family therapy practice elements predicts clinical improvements in adolescents with externalizing problems. So now that we are oriented to adherence and different types of adherence instruments, let's go back to our previous example. How can an adherence instrument help us interpret the results of our family therapy effectiveness trial? Scores of adherence to core family therapy practice elements across both the treatment and usual care groups would provide information about if levels of adherence in the family therapy group were sufficient to lead to improved clinical outcomes. And as a side note, the level of adherence that is considered sufficient can be informed through benchmarking trials. And adherence instruments can also provide information about if core family therapy practice elements were delivered in the usual care group. If they were, that would result in contamination bias and potentially minimize group differences in clinical outcomes. We've talked a lot about how adherence can help us interpret findings, but what about differentiation? Effectiveness trials evaluating evidence-based practices are doing so in routine practice settings, as opposed to controlled research settings, which are referred to as efficacy trials. In effectiveness trials in routine practice settings, it's not at all uncommon for therapists to use techniques outside of those that are specified as evidence-based for a specific problem area. As we know, evidence-based practices are not the end-all be-all of effective therapy, and techniques that are considered non-evidence-based for a specific problem area and population can be effective in reducing symptoms. Additionally, therapists in routine practice settings have been found to have a wide range of theoretical orientations and are usually treating multiple problem areas, often within an individual patient. So to understand what's being delivered in routine practice settings, we need an instrument of differentiation that captures a wide range of therapeutic techniques found across multiple theoretical orientations and problem areas. So back to our example, an instrument like this would help us determine what techniques outside of family therapy were delivered in both groups that may be positively or negatively impacting clinical outcomes. For example, were there techniques delivered in the treatment group that reduced effectiveness of the family therapy, or were there techniques delivered in the usual care group that increased the effectiveness of that group? Unfortunately, there are very few instruments that are conducive to thoroughly assessing differentiation. Given that the majority of existing treatment integrity instruments assess adherence only, capturing both adherence and differentiation would theoretically require the use of multiple instruments. However, using a single instrument to capture both adherence and differentiation is much more conducive to cross-group comparisons like family therapy and usual care, because item scores can be directly compared. To interpret mixed results from effectiveness trials, we would want to be able to compare groups on both prescribed and non-prescribed interventions, which requires a direct comparison of the scores of adherence and differentiation. In order to be a useful tool for our purposes, a single instrument that measures both adherence and differentiation should capture adherence at the practice elements level rather than protocol adherence. It should include techniques across multiple theoretical orientations and include techniques that are considered to be both evidence-based and non-evidence-based. And because youth presenting to community clinics often have symptoms spanning multiple disorders or problem areas, it should be non-problem specific. For family therapy, there are actually two existing instruments that were designed to assess both adherence and differentiation: the Inventory of Therapeutic Techniques for Adolescent Behavior Problems and the Therapist Behavior Rating Scale. The former includes both therapist and observer rated versions and includes techniques representing 4 theoretical approaches with evidence for treating adolescent externalizing problems, including family therapy, cognitive behavioral therapy, motivational interviewing, and drug counseling. The latter has an observer-rated version only and includes techniques representing family therapy and cognitive behavioral therapy. These instruments do capture adherence at the to family therapy at the practice elements level. They do capture techniques across multiple theoretical orientations. However, they only assess for techniques that are considered evidence-based for adolescent externalizing problems. So an instrument that has great potential for being able to assess adherence to and differentiation from family therapy is the Therapy Process Observational Coding System for Child Psychotherapy Revised Strategy Scale. And that is a mouthful, so I will be referring to it just as the TPOCS going forward. So this instrument is a 47-item observer-rated instrument designed to assess for discrete therapeutic techniques across several theoretical orientations, including family-focused, cognitive, behavioral, psychodynamic, and client-centered. Observers rate each item on a 7-point extensiveness scale representing the thoroughness and frequency with which a technique was delivered. Previous psychometric research with the TPOCS suggests that it can be reliably coded with mean intra-class correlation coefficients, which represent inter-rater reliability, ranging from 0.67 to 0.86. And the general rule of thumb is that ICCs greater than 0.6 are considered good, greater than 0.75 are considered excellent. And here is just an example of some of the therapeutic techniques that are captured. Every 5 minutes of a session that is being coded, the raters mark down some sort of symbol that represents low, moderate, or high extensiveness. And then at the end of a session, they use this form to provide an overall session extensiveness rating for each item. So going back to the characteristics that a useful adherence and differentiation instrument should have for our purposes of interpreting effectiveness trial results, the TPOCS does capture adherence at the practice elements level. It does capture techniques across multiple theoretical orientations. It does capture techniques considered to be both evidence-based and non-evidence-based for our problem area, which is adolescent externalizing problems, and it is non-problem specific. There is some evidence that the TPOCS can be used as an instrument of differentiation, specifically in a sample of youth with primary anxiety disorders who were receiving manual-based CBT or usual care. The TPOCS subscales were found to measure distinct treatment orientations, and they were able to differentiate between treatment groups and usual care. For example, in the study that I'm referring to, therapists in the CBT group delivered the highest levels of CBT, whereas therapists in the usual care group actually delivered the highest levels of family therapy. There's also evidence that the TPOCS can be used to assess adherence. In a sample of youth with primary anxiety disorders receiving either modular manualized CBT, standard manualized CBT, or usual care, scores on a TPOCS CBT subscale converged with protocol-specific adherence instruments. And this evidence is promising. However, you may notice that thus far, the findings have come only from samples of anxious youth receiving some form of CBT. And I've stated several times that a useful adherence and differentiation instrument should be non-problem specific and non-treatment specific. So the purpose of my dissertation was to examine whether the TPOCS could be used to assess both adherence and differentiation in a completely different sample with a completely different problem area, which is adolescents with externalizing problems, and a different treatment modality, which is family therapy. To represent adherence, a family therapy subscale was created from the TPOCS items that included items that mapped on to those core family therapy components that I presented earlier. And to represent differentiation, pre-existing subscales from the TPOCS were used, including the CBT subscale, psychodynamic subscale, and client-centered subscale. In order to produce scores that can help us accurately interpret what's being delivered in family therapy and usual care therapy sessions, and to what extent those are being delivered, the TPOCS would need to display certain psychometric characteristics. The first is inter-rater reliability. Items should demonstrate adequate inter-rater reliability, which represents the consistency among ratings provided by multiple coders. Higher inter-rater reliability would indicate that a lower proportion of score variance is attributable to the coders themselves, meaning that an entirely different group of coders should be able to rate the same sessions and come up with similar scores. The TPOCS would also need to display evidence of construct validity. Construct validity is the ability of an instrument to accurately capture the construct that it is claiming to assess. To provide an example, if you have a measure that's intended to assess symptoms of depression, but the questions are asking things like, do you often feel afraid? Do you often have trouble controlling your worry? That's actually probably better capturing the construct of anxiety. To break it down further, construct validity consists of both convergent validity and discriminant validity. Some people refer to the latter as divergent validity, and there is a technical distinction that I won't get into right now, but I'm happy to expand on in the questions at the end if anyone is really curious about that. Convergent validity refers to the degree to which two measures that should be theoretically related, as they are intended to measure the same construct, are related. For example, a newly developed measure of anxiety for children should be highly related to the screen for child anxiety-related disorders, otherwise known as the SCARED, as they are intended to measure the same construct. If they are highly related, this new measure would have evidence of convergent validity. Discriminant validity, on the other hand, refers to the degree to which two measures of different constructs are discrepant. For example, a measure of anxiety and a measure of depression. But this can get a little bit tricky because I'm assuming that when I said that, many of you thought, well, anxiety and depression are related, so we would expect to see a relation between them, which is true. And that's why the best way to assess construct validity is by examining the pattern of these relations. So in our example, that would mean that you would want our new measure of anxiety to be more related to the SCARED than to a measure of depression. You would also expect that new measure of anxiety to be more related to a measure of depression than to a measure of something unrelated like food preferences, for example. So I know this can be a little bit confusing, so I'm going to do my very best to try to break it down a little bit more in the next slide. In 1959, Donald Campbell and Donald Fisk proposed the multi-trait, multi-method approach to construct validity. And this method is based in looking at patterns of an instrument's relations with other instruments. And it states that construct validity is supported if the strongest relation is between two instruments of the same trait and same method. For our purposes, trait is just another word for construct. So to avoid confusion, I'm just going to use the word construct going forward. And method can refer to many things. For example, therapist report versus observer report, different ways of rating or scoring, things like that. So the strongest relation should be between instruments with the same construct and same method. The second strongest relation should be between instruments of the same construct but different methods. The third strongest should be between instruments with constructs that are related but distinct, like depression, anxiety. They're related to each other, but they are different constructs with the same method. Fourth strongest should be instruments with constructs that are related but distinct with different methods. And the weakest relation should be between instruments of constructs that are independent and distinct, like anxiety and food preferences. For the purposes of assessing the construct validity of the TPOCs, I conducted the following comparisons. The first column represents the correlation between the TPOCs family therapy subscale, which for the purposes of this slide, I will just be referring to as our family therapy adherence scale. And another already established observer-rated instrument of family therapy adherence. So they have the same construct and the same method. The second column represents the correlation between our family therapy adherence scale, which is again observer-rated, and a therapist-rated scale of adherence to family therapy. So that is the same construct, but a different method this time. And these two columns together represent convergent validity because we're comparing our family therapy adherence instrument to instruments of the same construct. The third column is the correlation between our family therapy adherence scale and observer-rated differentiation, which includes any non-family therapy subscales of therapeutic techniques. For example, CBT, psychodynamic, client-centered. So this comparison is between two instruments of the same method. Both are observer-rated and related but distinct constructs. So similar to how anxiety and depression are separate constructs but are related to each other, the constructs in this comparison are considered related because they are all therapy techniques, but they're distinct because they are from different treatment modalities. The fourth column includes the same constructs as the third column, but in this column, our family therapy adherence scale is being compared to therapist-rated differentiation scales. So this comparison now has a different method. And the final column represents the correlation between our family therapy adherence scale and an instrument of client-therapist alliance, which is considered to be an independent, distinct construct. So these last three comparisons represent discriminant validity. Construct validity would be supported if we saw this pattern of correlations between all of these instruments. And the last type of validity that I'm going to talk about today is a little more simple. It's called discriminative validity, easily confused with discriminant validity. And discriminative validity refers to an instrument's ability to produce scores that distinguish between groups that are expected to differ. For example, on a measure of sleep deprivation, we would expect parents of newborns to have higher scores than the general population. So previous research with our sample of adolescents with externalizing problems using well-established family therapy adherence instruments found that adherence was highest in a family therapy group, second highest in a group that received a combination of family therapy and something called the Medication Integration Protocol, MIP, which I will be expanding on in the next slide, and lowest in a usual care group. So for the TPOCs to have evidence of discriminative validity, we would want the scores to produce the same pattern. The sample of tapes that we coded with the TPOCs came from 2 different parent trials conducted by Dr. Aaron Hogue and his team. The first was called CASA-LEAP, and it was a randomized naturalistic trial of clinically referred adolescents with externalizing problems from community mental health clinics. The adolescents received either family therapy from community clinicians who were trained in and primarily delivered family therapy, or usual care that was not family therapy. Clinicians in both groups had no external training, supervision, or additional financial support. They did not use a manual and were not asked to adjust their usual clinical practices. The other trial is called MIP, which again stands for Medication Integration Protocol. And this trial was a pilot study with clinically referred adolescents with externalizing problems and comorbid ADHD. All of these adolescents were seen in a single community mental health clinic that routinely delivered family therapy. And these therapists were also trained in the medication integration protocol, which is a modular family-based protocol that integrates medication education and medication services into treatment. Our study included therapy tapes from 42 adolescents, 30 of which were from the CASA-LEAP trial and 12 of which were from the MIP trial. In the CASA-LEAP trial, adolescents were an average of about 14 years old. They were 50% male, 50% female. I do want to note that non-binary genders were not reported for these trials at the time. They were 66.7 Hispanic, Latinx or Latine, 13.3% Black or African American, and 13.3% multiracial. And 6.7% of youth reported identifying with another race that was not listed. For the MIP trial, the participants were an average of about 16 years old. They were 50% male, 50% female, and were 15% Hispanic or Latinx, Latine, 43% Black or African American, and 7% multiracial. The adolescents were treated by a total of 24 therapists. 21 were from the CASA-LEAP trial and 3 were from the MIP trial. Therapists were primarily female. Therapists in the family therapy group and the MIP group were primarily Hispanic or Latinx or Latine, and therapists in the usual care group were primarily white. Their average years of postgraduate experience was about 3 for all groups. So audio and video recordings of these therapy sessions were coded by 2 female white clinical psychology doctoral students who were 28 and 29 years old at the time. Training consisted of didactic instruction, reading a really thorough manual for the TPOCs, co-coding 5 training sessions and discussing any discrepancies, independently coding 10 training sessions and discussing discrepancies, and a certification period in which they each coded 30 tapes individually. And in order to be certified for coding, the 2 coders needed to have inter-rater reliability of at least 0.6 for all items across the 30 tapes. All tapes were independently coded by both coders, and the order of tapes was randomly assigned. A total of 103 tapes were randomly selected from the 2 parent trials, 49 from the MIP group, 35 from the family therapy group, and 19 from the usual care group. There were an average of 2.23 adolescents treated by each therapist and an average of 2.65 sessions rated from each adolescent's treatment. So now I will briefly present our psychometric findings. First, inter-rater reliability for the individual TPOCs items ranged from 0.56, which is considered fair, to 0.91, which is considered excellent. Only one of the items had interclass correlation coefficients below 0.6, and that was the 0.56. And the average item level ICC was 0.77, which is in the excellent category. Additionally, the inter-rater reliability for the family therapy subscale was 0.90, which is also considered excellent. So based on these findings, reliability was supported for the TPOCs in this sample. Moving on to construct validity, as I discussed before, what we really want to look at is the pattern of correlations, which are on the bottom of the screen in green. And the two sets of correlations representing convergent validity are significantly higher than the sets of correlations representing discriminant validity, which was confirmed with follow-up contrasts. You can also see that for the most part, the patterns of correlation are consistent with the multi-trait, multi-method approach, suggesting that construct validity is supported. The only exception that you can see is in the middle. One of the correlations looks particularly small, the 0.018, and that correlation was actually between the family therapy subscale and the client-centered subscale. And my theory of the reason that correlation is so small is because the client-centered subscale had high scores across every single session. There was pretty low variance in that subscale. And the reason for that is because the subscale includes things like validating client, getting the client's perspective. And those are things that you would hope most therapists would do in every session. So overall, this pattern of correlations does support both convergent and discriminant validity, which when looked at together supports construct validity. And lastly, we looked at discriminative validity, which as a reminder is the ability of the scores to differentiate between groups expected to differ. Previous research found that adherence to family therapy was highest for the family therapy group, second highest for the MIP group, and lowest for the usual care group. And that is the exact pattern that we found as well with the TPOCS family therapy subscale, which is supportive of discriminative validity. So our results were overall supportive of both reliability and validity for the TPOCS as an instrument of adherence to and differentiation from family therapy in a sample of adolescents with externalizing problems. Based on these findings, the TPOCS is a promising tool for understanding what therapeutic techniques are being delivered and to what extent, and helping us to accurately interpret findings from effectiveness trials. There are several limitations that I want to note. First, in its current state, the TPOCS is pretty labor intensive and it's not conducive to use by community clinicians or supervisors who are already very overburdened. So as of right now, it's more useful as a research tool than as a quality improvement tool. And second, the TPOCS does not capture specific information about therapeutic technique modifications, which are common in community mental health settings and important when working with diverse youth and families. Third, it's currently limited to the 5 different theoretical orientations and included therapeutic practices that are absolutely not exhaustive. For example, mindfulness interventions aren't currently included. Lastly, generalization of our findings are limited to samples of adolescents with externalizing problems. A future direction may be looking at another sample of youth receiving family therapy, but for other problem areas. And then I have some references that I'm happy to go back to if anyone wants to look at them more closely. Thank you all for sticking with me throughout this presentation, and I would love to take some questions.
Thank you, Stephanie. That was great. Let's maybe give people a second to collect their thoughts. And you know that you can write the questions in the Q&A that you can find at the bottom of your Zoom screen. Okay. And here we are. So again, for those who are listening, if you can take a moment and write your question, there's a Q&A button if you look at the bottom of your screen. Okay, and here is a first question. Let me read it out. I will read out these questions for our presenter. And here it says, let's see, how do you see, this is from Natasha Emerson. I don't know if I'm supposed to keep this anonymous, but I think it's great to get questions from our audience. How do you see this measure being used in underserved community clinics with young therapists new to the field? And yeah, is that clear? Yeah.
Yeah, okay. Absolutely. Thank you, Natasha, for your question. So treatment integrity measures can be a really helpful tool for quality improvement in community settings, and especially for new therapists who are learning how to do these interventions and want some way to track, am I doing the right thing? You can get feedback from these interventions about what you can improve on. But as I mentioned, this measure specifically is pretty labor intensive, and clinicians and supervisors and other staff who work in the community generally have very high caseloads. Those settings are pretty under-resourced, understaffed, and they definitely don't have time to be sitting down, watching an hour-long therapy video, coding it, being reliable with other raters. Like, that's just really, really not feasible for them. And so there are some characteristics that make a treatment integrity measure more feasible to use in these settings. So one of those is if they are therapist report. So if the therapists can just fill it out right after their session with what they did, that can be a much more feasible. And there are some mixed findings about the accuracy of those reports compared to observer report. But for family therapy, actually, there was a study done by Dr. Erin Hogue that explored therapist-rated adherence to observer-rated adherence. And for family therapy specifically, there was a high correlation. So therapist rating is one way to do that. Also, instruments that have the fewest number of items as possible. The TPOCS has a lot of items because the purpose is to serve for adherence and differentiation, which is very important. But the more items you add, the less likely it is that someone's going to be willing to fill it out. So there might have been some items on the TPOCS that for specific community clinics, they say, we never use this. We have never used this and we will never use this. You can take those out. And then the other thing is that there is some research currently going on at Virginia Commonwealth University looking at how much of a session do we need to observe in order to be able to get an accurate picture of the treatment integrity for that session? Can we pop into a session and see 10 minutes of it and get a fairly accurate picture of the extensiveness of what is being delivered, or do we really need to watch the whole session? And if we're able to shorten the amount of time and still get some helpful information, that can be used in community clinics. You're mute. Sorry, I'm done answering the question, but you're muted.
Thank you. I wanted to, yes, not add any noise to your presentation. Okay, thank you. And by the way, I am told a little note, the questions can be anonymous. So that's just in case that inhibits anybody from asking a question. I do have another question so that one was really about the community, real useful in terms of how you can adapt it, right, to community mental health settings. Another question is, in addition to aiding in the interpretation of effectiveness trial findings, what are some other uses for treatment integrity measures?
Yeah, so one of them we just talked about, so helping with new therapists in the community who are learning and wanting to track how well they're delivering their interventions, how extensively they're delivering them. They can also compare their own scores to more experienced therapists to see if they're kind of meeting those benchmarks. Treatment integrity measures are great for serving as internal validity checks for highly controlled research trials. They've been used for that purpose for a long time, and that was sort of their primary purpose for a while. They can also be useful for things like quality improvement and assessing the effectiveness of training and supervision. So you can send your clinicians to a training. You want to know, did that training actually work in changing therapist behavior? Or is the supervision actually helpful in changing therapist behavior or promoting the use of family therapy techniques? And so that's one use for it. And then they can also be really helpful for identifying specific techniques that are associated with improvement in clinical outcomes. We're still trying to figure out exactly what components are leading to these improved outcomes and for whom and when and why. And so being able to identify what's being delivered is a really important step in that.
Okay, thank you. So here's another comment and question, and I will say this one comes from Dr. Walshaw, our thought you would want to know, and it says, thank you for an excellent talk, Stephanie. It's great to hear that we may have an additional tool for family therapy adherence that works in other settings. And I think an important question, how much time do you think is a minimum amount to watch for a session to do an adherence rating?
That is a great question. And I don't have an empirical answer for that quite yet because that is the research that is ongoing, but I can speak from my personal experience. As I did the project that I was referring to, I was one of the coders for it. So I coded these sessions for the whole session, but I also coded them for 5 minutes, 10 minutes, 15 minutes, and 20 minutes. And the five was very short. If you get the wrong 5-minute segment, you're missing everything that they're doing. And so the real answer is the more amount of time that you can code is better. It's the more accurate picture of the session. But 20 minutes, I did feel like when you jump in right in the middle of a session, that's what we did. We went right in the middle, half point, and coded there. 20 minutes, I felt like we did get a pretty good picture for the extensiveness that therapists were delivering. You might not get all of the specific techniques that they're delivering if they deliver different things at different times, but you can get a picture of how extensively, how thoroughly are they delivering these techniques, which can be really helpful for training purposes.
Okay. That was a great question, right? Because it can feel so intimidating, right, to code a whole hour, 50 minutes, and 20 minutes sounds like it's a good thing. And I guess as I'm hearing that, it depends a little bit maybe in the goal of that particular study, if you want to do the whole thing. Okay. So right now, I don't see another question coming up. I'm wondering, while we wait, we have just a few minutes. While we wait for any other question coming up as you're talking, if there's something that's coming up for you, Stephanie, that you think with these questions and having done your prepared talk, that you'd like to add about your experience with this, or where you're going with this research in the future, if you are.
Yeah, I can talk a little bit about that. So my interests really are in how to apply these measures to community settings to actually be helpful for the therapists themselves. I think there is a very important use to them in research, but my personal interests are more in how can these really be used without overburdening people further, because we know there's incredibly high burnout in these settings and they have new mandates all the time. And, there's already so many things that they need to be doing. And so I am really interested in questions like, what's the minimum amount of time we can watch? Can we do therapist report? Can we minimize the amount of training needed for these measures? Can we maybe supervisors who observe the sessions? In community, it's hard because they're not sitting there observing the sessions. But if they have the time, maybe they can watch 10 minutes of a therapist session and use that to talk about, here were your scores. What do you think about these scores? And so my goal is to figure out ways to make these more feasible and more realistic and actually feel helpful for people rather than telling them, here's another thing you have to do. I would love it if they thought this could help me. I'll do this, but we're still quite a ways from that. I'm also interested in using these instruments in integrated health settings, which has not really been done very much at all because they're so fast paced, you're moving so quickly, there's not time for that. And so, and I, as someone who's worked in those settings, the idea of having to sit down and fill out some sort of an instrument after each session doesn't sound very pleasant to me. But excuse me. But I think there are a lot of researchers who are looking at, are there other ways that we can make sure we're delivering what we need to be delivering and track that?
Yeah. So we're coming to the end. I think that's great. And of course, I'm thinking, hey, we are in a training setting. Wouldn't it be great if there was something really fast to give us a sense of how the training is going and also give feedback Okay, and so that's a great thought, right? Always this sort of push-pull between utilizing things in research and how academic that can seem, and really applying these things in clinical settings. So we are at the end, and if there are any further questions, we can't get to all of them right now, but if there are any questions that come in, Stephanie, I hope it's okay for people to reach out to you.
Yes.
If questions come up in this area, they know you're an expert in this area, and just want to thank you for this presentation. It was great.
Thank you. Yeah, please, sorry to interrupt you. I just wanted to share my email address if anyone wants to reach out with any questions. It's just my first initial and last name, so sviolante@mednet.ucla.edu.
Perfect. Perfect. Thank you so much. And thank you everybody for having been here for this presentation. We look forward to the next one and look forward to seeing where you're going with all of this, Stephanie.
Thank you. And thank you so much for introducing me and moderating.
You're welcome. It's a pleasure. Bye, everybody.